So my name is Sharea and I work for the CLAHRC West, which is funded by the National Institute of Health and Research. Just a little bit about what CLAHRCs do across England, and what our CLAHRC is special about is that a lot of the work, nearly 90% of the research work, the ideas and the suggestions for research come from members of the public and members of the healthcare community. So this was one of those projects where we did that successfully, collaborating with some of the healthcare workers. Usually I talk a lot about how alcohol can cause malnutrition and how homelessness together with that can cause malnutrition. But with this audience, I'm sure you know more than I do how these two things work together, and people can get more and more ill, and they can get stuck in a cycle where they are too ill to do anything about it. They end up in the A&E, and then they are sent back out, and then the cycle continues, and there's a lot of ill health that isn't taken care of. And obviously that has implications for the society. So as I said, this project came about because there were two people in Bristol who had worked for a very long time with homeless people, and they were finding it difficult to access some information. They were finding it difficult to know what kind of nutritional needs they had, and particularly the ones who were, and quite a lot of them are, excessive drinkers. And one was Katie Porter, and the other was Claire Fleming, and they brought this project to us. They wanted us to find out for them what were the nutritional needs in the local people who were experiencing homelessness, and especially the ones with problem drinking. And we started looking for the answers, and during that process they also brought on board Adrian Bonner, who is from Salvation Army and is a nutrition and alcohol expert, and he advised us on some of the relationships and guided our project. So the question I guess we were posing was, what are the nutritional deficiencies? What are the ranges of nutritional deficiencies? And then is a good solution already out there in terms of whether it works and whether it's cost effective? So just very quickly, what we did was something that I do on a very regular basis. We planned systematic reviews. For those of you who might not know, this is just a way of collecting what's already there, making it go through a quality sieve, and then trying to find out what the actual answer is. Sometimes it can answer controversies, sometimes it can answer questions we didn't even pose. So we planned 2 reviews, one to find out the range of nutritional deficiencies in homeless drinkers, and then the second one on one that tries to find if a solution's already there, any intervention that might work to improve nutrition in them. And for this we searched 9 scientific databases, but we also searched a lot of other resources. Some of these charities were probably contacted either by me or by my colleagues over the past 2 years for asking for unpublished information. We found 9,216 references, and then assessed 257 of them to be relevant in full texts. And then for the first review, we could include 9 studies only, and the studies range from 1940s to now. Just 9 studies that ever assessed what are the nutritional deficiencies in homeless people. And then for the review of interventions, we found quite a lot more. They had assessed different ways of addressing the malnutrition. We did the standard data extraction and quality assessment, and then synthesized it narratively because everything was very diverse. It wasn't possible to do, or it wouldn't have been right to do any analysis in a statistical way. So what we found was that deficiencies exist. We also found that the most common one that's studied is vitamin B1. Everyone thinks that if you're homeless, you're likely to drink, and therefore you must be deficient of vitamin B1, which is thiamine. But what we also found was that every study that looked for the other 2 found a large proportion deficient in that. And that was quite a new rather unexpected finding for us. And then we found that so many haven't been addressed. And I guess with vitamin D particularly, we all know how it protects against so much of infection and even cancer to some extent. So that's another big gap. The biggest finding for us was that there was no study on the nutritional profile in the UK. Most of the information was coming from the US, a few old studies from Europe and Australia, but nothing from UK. And we couldn't find any specific clear subgroups within the homeless people who were suffering from nutritional deficiencies. So we couldn't say if it was a gender difference, if there was an age difference. We did see some regional subgrouping, so that might have something to do with diets because they vary across the world. So we had one study which was from South Korea, and obviously their diet is very different from the Western European diet. And again, we couldn't find those trends in time or across places or across other groups because there weren't enough studies to actually see that. So I guess what we found was that we need a new study locally if we want to know what their needs are. And for the intervention review, we found there were 3 main types of interventions: providing education and support, which was largely happening in shelters, providing foods and meals, cafes, soup kitchens, things like that. And something very special, which was fortifying food and providing it, or adding supplements to diet. And what they measured was intake, acceptability, very important, and just a few of them measured cost, but none of the studies assessed any disease or health outcome. So if they carried on an intervention for a year, at the end they say people like it. And they say it was accepted, and they say, yeah, nutrition intake improved or body weight slightly improved, but they wouldn't be able to say if it was improving their health or reducing their disease, something that we found is very important to decision makers, and we haven't got that evidence for them to fund anything. So a quick look at the studies that we had by their division, and an overall impression from the studies in education and support. One was that it does improve healthier food intake, but we won't know if that would work in people who sleep rough, because shelters have the ability to provide that structure for regular contact and providing food as well. Food provision worked, and we did find one study which tested a menu change, and people loved beef burgers and hated salmon pasta. And they liked apple crumble, and they didn't like yogurt and plum pudding. I don't know who planned that, but yeah. But most of the 5 studies showed that the adult daily requirements are not met by shelter foods. And there were 3 studies, rather old really, and they included both rough sleeping people and shelters. And they were, so one was about giving them a fortified chocolate spread, which was developed with their input, so they really liked it. But then we've learned since that thing has been patented, so no one can use it anymore. So we need to come up with something on our own again. And then 2 studies, one providing oral vitamin pills and the other providing vitamin injections. Both showed that deficiency levels in the blood improve and stay improved. But again, no long-term health outcomes. And a multi-component interventions, they were very interesting because they combined some component of them, these 3 categories, with either another one from them or something else, like giving cash or giving food, but giving a cooking facility as well, or adding education and support with detoxing. And that was another interesting thing because it showed that adding multiple components together to an intervention, making it more comprehensive, can increase intake, but the detox study along with education showed that the liver function didn't improve. So this was the only health outcome we could see. Some were acceptable. They were both from the US and both more recent. The first one, the Kenzo study, was a very comprehensive one. They gave them pedometers, they gave them fruit snacks, they gave them goals to achieve, in a shelter setting. And then the other one was a clinic setting with detox and teaching them how to eat more healthy. And that one, people didn't really like it. We were hoping to find someone to have done a cost effectiveness analysis that would have made our life easy, but we didn't find any. What we did find was some cost studies, which basically say that if you were trying to give someone a B complex and vitamin C tablet in the 80s, that would have costed you a daily thing of that per person, which is less than $1. And then a chocolate packet and a meal per day in 2009 would have costed $5. That was in France. And a food pack was given to homeless people who were attending a tuberculosis clinic in Russia, and they found that the attendance improved to 90%, and most people completed their treatments just because they were getting that food pack. But again, we didn't have anything more than the acceptability and these cost outcomes. And then one study which provided cooked meals, and that appears to be quite cheap. So overall, we had only 2 studies from the UK, and I found very interesting that one of them was about providing education and support, and that was developed by the staff in a shelter. And they said that the patient, the participants might like to have instruction on how to cook and hygiene and food, looking after food, how to store it. And no one showed up. Like, some of the sessions were quite empty. Whereas the meal provision one, which tested a menu change, they actually measured that some were, as I said, some liked beef and some didn't like salmon pasta. So I think they provided more answers than not that. And then comparing the Hinton study with another study from the US, where they asked residents in a shelter, what would you like to do? And then they came up with the same intervention, but because they had developed it themselves possibly, they were immense uptake, and they finished the intervention as well, but there were no health outcomes or any other effectiveness outcomes. So one thing we're trying to do is to disseminate it to people who are on the front line, instead of circulating in the academic circle, because I think that if people in the front line know, maybe they can use this information better than I can. And then trying to contact all the people who have been helping us providing data in the past as well. We did try to get funding for these 3 things over the past 6 months or so, and we've just got refusals everywhere. So that's something that I think is quite common in this field, because it's important enough to be talked about, but not many people are willing to put money in, and I think there's a lack of political will, but that's just my personal opinion. And we found out that there are interventions ongoing at a local hospital here and in Bristol, and therefore I'm sure that there are interventions happening everywhere else as well. If only we could join things, I think, and that point has been brought up before as well throughout, that I think we need to join hands if we want to really find an answer to this. Thank you very much for listening, and I appreciate it.